All right, for my second case study, I'm gonna be doing hepatopulmonary syndrome. Um, and just give you guys a quick little background before we begin. Um, Hepatopulmonary syndrome and end-stage liver disease is really reported between about 4 and 47%. There's three pieces to that criteria during diagnosis. So liver disease, hypoxia, and evidence of intrapulmonary vasodilatations. The hypoxemia is from a combination of mechanisms. There's a VQ mismatching with vascular dilatations causing an increased perfusion of the alveolar capillary bed. The dilated capillaries surrounding the alveoli lead to reduced oxygenation of red blood cells. By increasing the distance that oxygen must travel to them. Both mechanisms are further exacerbated when the dilatations result in increased perfusion to poorly oxygenated areas of the lung. Physical shunting via direct arteriovenous connections by bypassing the alveoli can also occur through this less common than pulmonary vasodilatations. Liver transplantation is currently the only effective treatment, and prognosis is poor without this. Saline contrast echo has been shown to be a highly sensitive test in confirming the intrapulmonary vascular dilatations. So now, for the case study, I have a 42-year-old male with known alcoholic liver cirrhosis was admitted to the hospital with abdominal distension, jaundice, breathlessness, and lethargy. On exam, the patient appeared cyanotic with clubbing of the fingers and toes, and he was noted to be hypoxic and tachycardic with a pulse of 109. In addition to this mild pitting peripheral edema, hepatosplenomegaly and florid spider nevi were also present. The blood test showed a mild normocytic anemia, thrombocytopenia, and normal liver function when clotting and keeping this liver disease. When the EKG was unremarkable and ambulatory blood gas analysis showed type 1 respiratory failure. A routine chest x-ray did not reveal any cause of hypoxia. And to exclude pulmonary embolism, a CT pulmonary angio was performed but no abnormalities were found, including no evidence of AV malformations. A subsequent overnight oximetry was not suggestive of OSA, and routine lung function tests were normal. Transthoracic echo showed borderline left ventricular dilatation with normal systolic function, normal right ventricular size and function. There was mild biatrial dilatation, but no evidence of an ASD. In view of this persistent and unexplained hypoxia, the patient was referred to the physician who felt that the patient may have developed hepatopulmonary syndrome, and referred the patient from an agitated saline contrast echo to confirm the diagnosis. Contrast can be observed arriving in the left heart chambers 6 beats after entering the right, with maximum pacification achieved 8 to 10 beats after initial contrast appearance. In conjunction with this patient's presentation and the medical history of the alcoholic liver disease, this confirmed the diagnosis of hepatopulmonary syndrome. A CTPA can detect AV malformations. However, it does have limitations as to the size of malformations it can detect, and obviously it will only identify those within regions scanned. Therefore, the delayed appearance of agitated ceiling appearing in the left heart helps confirm the diagnosis, but cannot differentiate between passage via the dilated capillaries and the AV shunts. Treatment and outcome. There was, following the diagnosis of the hepatopulmonary syndrome, the patient has now been referred to a tertiary center for consideration of a liver transplant. So, lung perfusion scans using macroaggregated albumin are an alternative to saline contrast echo. However, they're more invasive and they're less sensitive and cannot really distinguish between the right to the left flow as a result of the intracardiac or extracardiac pathology. The frequent presence of esophageal varices in these patients with cirrhosis also promotes the use of transthoracic echo first line in preference to transesophageal echo. Agitated saline microbubbles are usually prevented from entering the left side of the heart due to the size being too large to pass through normal capillaries. Pulmonary vascular dilatations or arteriovenous malformations allow passage and thus opacification of the left-sided chambers. Intracardiac shunts with right-to-left flow also result in a positive study. However, timing of the number of cycles from appearance of bubbles in right-sided chambers to appearance on the left enables for differentiation between the two. Left-sided bubbles appearing within 3 beats are consistent with an intracardiac shunt, and 4 to 8 beats with the extracardiac cause. The degree of passage through the lungs can be quantified from the number of bubbles seen on the left side, under than 5. Small, 5 to 20, moderate, greater than 20, and large. Pulmonary vascular dilatations tend to be more prevalent in lower zones, and therefore detection can be improved by performing the saline contrast study in the supine and standing positions due to the gravitational forces, increasing the blood flow to these zones in the upright position. This is also the basis of orthodoxia, and for those of you that know, that's pretty much where there's a lower sats on supine to upright. So, and this can be also observed in hepatopulmonary syndrome. In addition to scanning these postures, performing with and without a Valsalva maneuver or cough is also recommended during the saline contrast echo. And the use of provocation maneuver induces a transient rise in right atrial pressure and can help unmask intracardiac shunts. When performing a Valsalva maneuver, a patient should be asked to strain as an injection takes place and then release once the bubbles were seen entering the right atrium. The false positives for extracardiac shunting are possible either due to the delayed intracardiac shunt or the PFOs resulting in pleutypnia, orthodoxia syndrome. And it's also possible for large pulmonary vascular dilatations to result in a quicker passage of bubbles appearing within 3 beats and making distinction between intra and extracardiac shunting more difficult. And in the echo department, agitated saline studies are performed using 8.5 milliliter normal saline, 1 ml of patient's blood, and 0.5 ml of air, and that's consistent with other labs. And once drawn up, the mixture is agitated by passing between 2 ml Luer lock syringes by a 3-way tap. And some studies don't really recommend the use of patient's blood and suggest that the effect of bubble stability is not sufficient when balanced against the risk of blood product spraying spillage when mixing. But the use of Luer lock syringes minimizes the risk, and the left antecubital vein is most commonly used as a site of injection. And there's evidence that injection by the via the femoral vein can increase diagnosis for intracardiac shunts, but that's impractical pretty much. Other than that, these are my references, and thank you for listening.